This is abdominal, plain abdominal X-ray, but there are different densities. But from there, you can say there is a bone here, there is air here, there is fat here, and from there you can even diagnose a disease. All right. Like now, that metal, I think that metal was inside the stomach. That patient was ingested some metal, like a coin or something. All right. So there are now some factors that can contribute to the film quality, because when you are doing X-rays, producing X-rays or images in radiology, you have to take care of the quality for radiologists now to be able to diagnose a disease. So the factors now that can contribute to that film quality, there is number one, obesity. Obese people, they produce very bad images on X-rays. But for CT scan, it is good. They produce very good image. For ultrasound, very bad. So obesity can change the quality of an image. Movement. If you are taking an image, X-ray, ultrasound, fluoroscopy, even CT scan, even an MRI, we always tell the patient not to move at all, to stay in the same position, even to stop breathing, because if that breathing movement can reduce the quality of an image. Another factor is about magnification. You know it very well. If you magnify an image, a picture on your phone, it loses the quality. That one, you know, even from the normal photography. Scatter. The scatter, when you send the X-rays and they deviate from the original line. Scatter or defection, defected or scatter, they change the orientation. That can change even the quality of the image, because X-ray, the origin of the X-ray on the film will go to another area, not at the same area as the same line from the origin of the X-ray. That's scatter. It can reduce the quality of an X-ray. Do you understand this? Or you have any question here?
No, I don't have a question.
Good. So, plain film or convention X-rays.
Get on the scatter. The point of
scatter.
Yes.
Scatter, it's when X-ray beam, by reaching the body of the patient, they change the orientation. They are deviated from the origin, from the X-ray beam. They change the orientation. That's scatter. The scatter, it can be caused by many things, but even the structure of the body. Instead of absorbing the X-rays, some structures like bone, like metal, it can now deviate the X-ray beam to another orientation, to another direction. All right?
All right.
It happens. But in X-ray machines, there are some other material we use to reduce those scattered X-rays to reach the film. Because if they reach the film at a high number, they will change the image. So we use other material they put on the machine, X-ray machine, so that those scatter X-rays can be blocked from the X-ray machine before they reach the patient. All right? So, plain film can be used. Especially they are used for chest. You know, the majority of procedures we do in X-ray machine, it's about chest X-ray. Plain abdominal X-ray also it is done, abdominal X-ray frequently. In case of trauma from the spine, from long bones, from the chest, we can use X-ray, plain film. Skeletal disease, bone tumors or osteomyelitis infection, plain film can help much. Those are 4 areas where we use plain films, especially. We are talking about conventional film, conventional radiography, plain films. We come back now. We come back to the density. What do you think this density is here? This is chest radiograph, chest film.
Yeah.
Air. Why do you say this? This is air. Why?
It's a black.
The film is black.
So what happened when you are taking this image? What do you think happened?
There was no inspiration of air. Small quantity of air inside.
No. Because in the lungs there is much air, a lot of air. Listen. So X-rays have passed through it very easily and reached the film. And the film now, on the film, it became dark. Seriously? Nibyo nashaka ko mwumva kugira ngo mujye mumenya gutandukanya. So what happened here on this is the spine and the heart. It is white. What do you think happened?
There is a scattering and the destruction of the X-ray.
No.
Absorption.
Absorption, yes. Blockage of absorption. And what? It's absorption. So not all X-rays have passed through this structure to reach the film. So it becomes now white. All right? Seriously?
Yego.
Nibyo.
Ko mugaragaza nkaho mutabyumvise none.
Twabyumvise.
Ufite abanyamahanga mu ndani, hari abanyamahanga mwigana?
Yego, umwe.
Umwe, okay, so this is hello? Okay? Can you hear me?
Yes, we are hearing, sir.
This is a abdominal CT scan, an axial view, abdominal CT scan, where we have like, this is the liver here, this is the kidney, this is another kidney, the left kidney, this is right side, this is left, this is a bowel loop where we have some fecal material and the air. This is the vertebral body here. These are vessels, like this is the aorta, abdominal aorta. Those are branches of the aorta. Those are soft tissues like major psoas muscles here. This is gray. Can you see how the subcutaneous fat, the gray density here? This is soft tissue density here. This is the bone density here. Can you see the difference? So I wanted just to tell you from this one that all modalities that use X-ray, they all have those 5 densities. All of them, like I say, plain conventional X-ray, fluoroscopy, mammography, CT scan, all of them, they use those 5 densities I told you. Okay? Like I told you that plain X-ray can be very well in diagnosing fractures, long bone disease. Like this is a fracture. Can you see that you cannot miss this from just plain X-ray? All right? Any fracture or any bone disease, it is easily diagnosed on plain X-ray. Let us go. Janet ari he? Kare bonzi mwenyine mumbwira ndi mazina njya mpamagara. Tianga Mumgiri Dumon. Janet, where are you? Abubakar.
Yes, Prof.
Hey, Janet can hear me?
Yes.
Answer number 1. Which density is that?
Light gray.
Number 1. Oh.
Yes. I can.
No. Number 1. Sure?
Light gray.
No way.
Light gray.
Okay. For which density is that?
For number 1.
Soft tissue.
Soft tissue. Okay.
Yes.
Number 2. You are right. Number 2.
White metal.
Metal.
It's very
Number
white.
3. Number 3.
Soft tissue again.
Oh yeah. Number 3.
Gray. It's fat.
It is air.
That's air. In the stomach, by the way.
It's air.
And number 4.
Just a black.
It's a bone.
Number 4.
Number 4. It's off white.
It's bone.
It's a bone.
Okay. I just want to make sure that you can differentiate those densities and recognize which structure is that. That's now the basic. It's basic knowledge in radiology. What density is that?
Metal.
It's a metal.
It's a metal. Good. That's a metal for sure.
Yeah.
So they are now what are the advantages of X-rays or radiography? For number 1, I have said already, it is inexpensive. I told you it's radiographic machines everywhere in the country, everywhere, private, public hospitals, district, they have X-ray machines. So it is available. It is inexpensive. And the third, number 3, is excellent spatial resolution. Spatial resolution, you have to understand this. General X-ray or conventional X-ray has more spatial resolution, better spatial resolution than CT scan. How? Spatial resolution is differentiating. Follow. Spatial resolution, it's when you can differentiate from one density to another, from one organ to another one. Like if you take a picture of your upper limb, the upper limb, you can say this is fat, this is soft tissue, this is bone. That is what you call spatial resolution. Excellent spatial resolution, good spatial resolution. And again, advantage, it is a real time for fluoroscopy. I told you, special exam fluoroscopy, you can see things that is happening inside your body. It's a real time examination, real time procedure like fluoroscopy. That's another advantage for X-ray procedures. But also they have a limitation. The first limitation, it is all the images are 2D dimension. 2D images. So for suppose that I have a coin on my chest, right? I have a coin on my chest and I take an image of the chest, X-ray of the chest. You cannot know that coin is inside lungs, behind, or out of the body. You can't, unless you do another third dimension image. But also remember, we can do what you call lateral view. Can do frontal view and lateral view. By the way, the role of lateral view, it's for location of a disease, because from the front of view, AP or PA, from front or from that's tumor. That now, has very poor toxicity. Now, this organ in the spleen, can you differentiate the same organ? Can you differentiate point 1A from point 2 from B? You can't. That we call contrast resolution. So X-ray now is very poor in differentiating in contrast resolution. That's what I mean. Number 3, it is only useful for radio-opaque foreign bodies. If you are examining, you are looking for something that is non-radio-opaque, that's not, when you take a picture, it cannot be shown on from X-rays. Yeah, that's another limitation. For CT scan and MRI, you can still see something that is that's not radio opaque. You can see it. There are some like stones that are not radio opaque. Did you know? Did you know that there are some like stones, like other structures that are not radio opaque? Love, when we do X-ray, conventional X-ray, you can't see it at all. But when you do ultrasound, you do CT scan, you can see still something. Number 4, it is very useful when you have like emphysema. Emphysema is air in the soft tissues or in subcutaneous area, or free air present. When there is no air, like for example, someone has had trauma, injury, and of soft tissues, there is no emphysema, there is no air present of the air, and you do conventional X-ray, you can't know what's going on. You can say this is normal. While when you do an MRI or ultrasound, you see, there is injury of soft tissues. So meaning there is a limitation of conventional X-rays for when there is no air. When there is no air, you can't tell anything. And number 5, all procedures, modalities using ionizing radiation, they use radiation X-rays, and X-rays are ionizing. They can produce ionizing radiation, which can cause cancer and everything. Other harmful. They are harmful to the body. So X-rays are ionizing radiation. So you have to know it very well. That's, remember the picture, the list of the X-ray. When I was asking you which modalities here can use ionizing radiation, and you told me you don't know at all, like CT scan, conventional X-ray radiography, fluoroscopy, nuclear imaging, or mammography. All of those, they use ionizing radiation. But MRI, ultrasound, they don't use ionizing radiation. They don't have any radiation to the body, any radiation exposure. MRI and ultrasound, they are very safe in terms of ionizing radiation exposure. But the rest, using X-rays, they have that exposure of radiation.
Oh yeah.
Yeah, good.
That's the reason why when we are requesting for any imaging modality for your patient, you have also to consider either the cost, you consider the availability, you consider the capabilities of that modality to diagnose a disease, but also you consider ionizing radiation exposure. Because especially for children and for pregnant patient, you cannot just say for CT scan of the abdomen while the patient is pregnant, or for young children, you cannot just send them for X-rays frequently without any limitation. You have to think of this ionizing radiation exposure that can cause other serious diseases. That was, I have just finished conventional radiography. The second modality I want you to know a bit is about what you call conventional tomography. It is no longer used because it has been replaced by cross-section imaging like CT scan and MRI. This was a modality done by a fluoroscopic machine where when you see something that's not clear, when an object is obscured by overlying structure, now there was a technique where you are moving the X-ray from the receiver, from the cassette. Now they go into different direction, and from there you cannot now see better the structure you wanted to see from the body of the patient. It is no longer used at all. Don't even take time for this, but I give you an example of this image. This was conventional tomogram, where you do fluoroscopy of the chest and you see structure here. You can see this structure here, the disease. Now, when you do conventional tomography, you can see it better. Can you see that on another image? It's far clearer than the first one. That was a conventional tomogram, but don't even remember it because it's no longer used at all, because it was replaced by cross-section imaging. Number 3 is about fluoroscopy. Now you are familiar with these terms. Fluoroscopy is a real-time radiography. You remember it allows continuous viewing of X-ray image. It allows live visualization of dynamic event. All right? Like in barium swallow, you give a patient to swallow some contrast, a dye. And now the machine will follow that dye coming from up to down. Now you can know that there is an obstruction here, there is a tumor here, there is any lesion, you can know it. In fluoroscopy, we can do, it is a continuous low power X-ray. The low power X-ray, different from the X-ray, the energy we use in conventional X-ray, but in fluoroscopy, it's a low power X-ray passing through the patient as we are following on the screen. So, for example, it can be used barium studies, as I said, barium meal, barium swallow, barium flow through, I told you, barium enema. It can be used in arteriogram when you are following the dye, the contrast into the arteries, and you know where is obstruction, where is the disease, myelogram from the spine, and intervention techniques, different intervention techniques, we'll see them later. So that is fluoroscopy. Any question here? Do you have any question on fluoroscopy? No question? Can I continue?
Yes.
Okay. So this is an example of fluoroscopic machine. Can you see? Even the operator, the technician or the doctor is within the film, within the field of X-rays. He's with the patient. Now, can you see that the operator is looking somewhere else? Now he's looking at the screen and he's imaging the abdomen, but looking at the screen and see in real time what is going on within the abdomen. And this can be changed, can be in other direction, can move the table, you can move the machine itself, exactly to look where you want to look, to follow that dye, that contrast within the body. You know, the operator is looking at the screen. They didn't show the screen where it is, but he's looking at the screen and follow in live following what is going on. All right, so if when you come for rotation, you will see these machines and remember that I have seen them in the class. Like for example, this is a male. Can you see? Like me, I know the esophagus coming up. This is the stomach, the fundus of the stomach, the body of the stomach. the pylorus at this level. So you can, from there, you can follow and see where is the skull, where is the ulcer, where is the tumor. If it is normal, it is big. If there is stenosis, reduced in caliber, you can diagnose. And the contrast and the white is contrast. Then, because they remember contrast high atomic number, and to make the film to be white. All right. And even the small intestines, can you see these small intestines? There is some dye contrast within it. You can even follow it and see where is the problem. All right. But for barium meal, it's normally you check the esophagus and especially the stomach. All right. Barium swallow for the esophagus. Barium follow through for the small intestine. Barium for large bowel. I'm telling you, you have to know them. All right. Aje?
ayo mategeko
Mwayumvise ariko
oya kereka niba ari ahantu
ntago tuyazi ntago
ariko se nimwayamenye. Barium meal for the stomach.
tuzi
Barium swallow for the esophagus. Barium follow through for the small intestine. Barium enema for the large bowel. Sibyo? Ariko ntacyo muzamenya neza ni mwaza muri rotation.
ya small bowel ntabwo twayumvise.
Small bowel. Barium follow through. Na iberetse.
Yes.
Follow through. All right. So, for example, this is an image of barium swallow. Remember barium swallow? Barium swallow, it's about esophagus. Can you see that there's some discontinuity? There's some filling defect. Can you see those dark? We were supposed to see it like whitish here because there is a dye, there is contrast within the esophagus, but we see some filling defect, dark filling defect, That's how this is typical for esophageal varices. So me as a radiologist, when I see this immediately, I know, there are some varices, esophageal varices. Not even esophageal varices, you can diagnose any ulcer, you can diagnose any esophagitis, you can diagnose any reflux, you can diagnose any a tumor, esophageal cancer, tumor, diverticulum, you can see it. So you can diagnose different diseases from this examination. All right. I have just given you an example to see that barium, that fluoroscopy can diagnose, in real-time examination can diagnose the different diseases. So number 4 is about mammography. Remember I told you mammography, it is X-ray of the breast. The machine we use in mammography is different from what we use in radiography, in conventional X-ray. No, they are different. Here, it's a special X-ray machine where now we can diagnose a disease from the breast. You remember from the first or second slide I told you about screening mammogram and diagnostic mammogram. Screening mammogram is when the patient comes without any symptom, just to see if she has or he has, you can even do this to men, if he or she has a breast cancer or any other disease without any symptom. For diagnostic mammogram now, they come with symptoms, either feeling a lump or a mass in the breast, or pain, or discharge, breast discharge. That time now it is no longer a screening mammogram, but it becomes a diagnostic mammogram or mammography. All right. But in the breast, mammogram can show either calcifications or masses. All right. And here I can tell you, mammogram is always done with ultrasound of the breast, because you remember the densities I told you, different densities. When you see a soft tissue mass in the breast, all right, that's a soft mass. You can't know if it is really, is it a cyst? Because they are white, fat is dark. For those old people, the breast tissue becomes now fat. That's the reason why mammogram is not done for very young patient. Very young people, young girls, you cannot do mammogram because the breast is used by fibroglandular tissue, which has it's dense. It is dense and it is white. If white and even tumor is white, how can we differentiate both? So it is useless. But for old people, the content of the breast is 90% or even 100% fat, and fat is gray. If there is a mass, even it is very small or calcification, you will see it immediately. But even if you see it, you can't tell if it is cyst, the mass with fluid content or soft tissue content. That's the reason why after mammogram, you go to ultrasound, and ultrasound can very well differentiate a cystic mass, a mass with fluid content, from a solid mass with soft tissue content. All right? Any question here? Before I go to next. Any question? No. So this is an example of mammographic machine. Can you see here? The breast, you put the breast here and you try to compress it so that you can maximize the chances of diagnosing a disease. You compress the breast here, and this is now in where the technician, the one who is doing mammogram, can use this machine to send X-rays so that you can take a picture here on this screen. Right? That's how mammographic machine is. For example, now the procedure now, can you see it can change the orientation from, and it can take either craniocaudal from up down or lateral oblique, like in this case, this is lateral oblique. And now the operator can you see how the image has been processed? The dark gray is fat. So meaning this patient is not that young. Even if from behind you can tell it is young. All right. But the content of the breast is 90% fat. It's gray, dark gray is fat. So meaning this patient is not that young. If it was young patient, it should be white. The breast should be white, and you cannot differentiate from that white from fibroglandular tissue from another mass or tumor. All right. So yeah, this is another image. Try to show you how we can have different. The breast can show on the image differently according to fibroglandular, like whitish things, structures you see it is fibroglandular tissue. The dark gray, it is fat. But on this another breast, you see the fibroglandular tissue is more in this image than this one, and the fat is less here compared to this one. So this is maybe according to the age of the patient, or even to different, even if patient have the same age, they can have some people because of the different hormonal level, they can show the image of the breast, different image of the breast. For people who have a lot of estrogen, for example, they have a lot of fibroglandular tissues like here, compared to those patient who have less estrogen level. So another modality I want you to understand is about CT scan. CT scan means computed tomography. Computed tomography. People can call it CT scan. Other people call it CAT scan. Others Spiro CT. Others Leica CT. And it was discovered around 1972. for the first time. And now we are going to another different procedure, because a CT scan, it is a cross-section imaging, where now we try to cut the body into slices, different multiple thin slices. That's the reason why CT scan can give you more details, even contrast resolution, high resolution compared to conventional radiography. So CT scan show a slice, different size or cross section of the body. The image can show your bones now. CT scan is good in showing the bones, the other organs like or soft tissue organs in the body, soft tissue like muscles, than compared to the conventional radiography. And because the image is done by computer, you can manipulate it. You can make it big. You can change the density, the contrast, The operator or the radiologist can change the density, the contrast, the way he needs it to be for him to be able to diagnose the disease. CT scan can show tumor shape, even conventional radiography, but CT is better. The size, the location, here it is even better because this is now in 3D. Normally we scan in 2D, like in axial CT, but after that we do what we call reconstruction. We can now create other images in the coronal view from up down or sagittal from side, for you now to locate a tumor or disease. We can even diagnose some blood vessel disease. CT scan can also be used in biopsy, what you call CT guided biopsy, or even in radiotherapy. CT scan can be used in follow-up of disease. I told you. We do CT. We found a liver mass, a liver tumor. We give medication, and after 6 months, we do another CT to see if that has reduced in size or it has increased in size. That's a follow-up, or it has disappeared completely. And I have told you that the machine can create a 3-dimension, what you call, no. A 3-dimension is different from different views. 3-dimension, now you see the body as it is, as if you are operating on the patient. Now, this is now how the CT machine looks like. All of them, they look like this. You can see a bed, the bed where the patient lie on. This is now the machine where the X-ray comes from. X-rays come from, and now this is the place for the operator with the computer screen and even the computer here. Now it's manipulating this machine from from out of the room. Now the operator can move the table and this machine as according to where you examine. Now the machine will send X-rays and produce the images here, right on the screen. All right. For example, these are images, axial CT of the brain. From here, X-ray cannot produce, general X-ray cannot produce this image of the brain. But this is the different slices are different levels, because this level here is different from here, because here, like now, you cannot see the ventricles. But from here, you can see the ventricles. From there, you can even see them better. Here you can even see the posterior horns. Here better. Here, so those are different sizes, are different levels. Those are slices, cuts of the head. And from these images, you can see the brain, the ventricles because the fluid. On CT scan, fluid is dark. On conventional radiography, fluid is white. That's very important, by the way. Other densities are the same. But from fluid, CT scan fluid is dark. Conventional radiography fluid is white. Okay. Can you see this whitish? See this whitish? This is fresh blood. What you call extradural hematoma. That's acute, fresh blood. You know, it is easily seen on CT scan, but on conventional X-ray, you cannot see it here. All right, okay. These are different images done by CT scan, computed tomography. This is a 3D image of the head. This is a 2D images, coronal view of the brain, axial and sagittal. This is 3D dimension. You can produce in CT a 3D dimension. It's like you have removed these bones from the body. This is a 3D. It's a 3D dimension. Even this is 3D of the heart. Can you see how CT can be good? And produce like look how this hand, how the hand, the carpal bones here, the metacarpals, the joint, you see, very clear. The chest, you can see the ribs one by one. You can see the heart there. You can see the head. You can see this is the ankle joint, where you can see the talus. You know, everything is very clear. The fracture, you can diagnose the fracture very well from there. All right. Is it okay? So, are you following?
Yes,
we are following.
Yes.
Good. So in a CT scan, we can produce different window, what you call windows. Windows, it is you change from soft tissue density to air to bones. For example, if you do a CT scan of the chest, and I want to see better the mediastinum. And remember, the mediastinum, it is a soft tissue, it has soft tissue components. Now, I will change from the machine, from the computer we use in the CT as we are reporting. I will change that image into soft tissue window. We call it a window. Soft tissue window, so that I can diagnose better mediastinal lesion or mass or tumor or any other lesion. Now, when I want to see better the bones, I will change that image from soft tissue to bone window, so that I can see better the bones. All right, that's the image. That's like a bone window, soft tissue window, where the mediastinum very well seen. And number 3, I can even change the image from those other 2 windows to what you call lung window, so that I can see better the lungs with the vessels. Like here, you can see the lungs with the vessels passing through, pulmonary vessels passing through the lungs, you know. So CT scan has that capability of changing the imaging in different windows, but you have only 3 windows plus 3 dimension I have shown you. All right. Ibingiye murabyumvisa ko muzabyumva nimwaza muri rotation. Okay. Ariko n'ubundi ngiye kujya nkomeza mvuge. I have a concern when no one say anything. Maybe I think, are you following, or am I still connected? But if it was about question, in French we say "Kino dimo concern." If you don't stop me, I suppose that you have understood very well. All right. But my concern is, are you still following or not?
Yeah,
yes.
following.
Thank you.
Okay. Yeah. So, this is which CT scan is this? Abubakar,
Abdomen.
abdominal CT scan.
Yeah.
Which view? Is it coronal? Is it axial?
Transfers.
Axial.
Yeah.
Can you, okay, whatever. This is an axial view. Can you differentiate now? You see how CT scan is very good. X-ray, conventional X-ray cannot produce this kind of image. This is one slice, by the way. This is the one cut at the level of the kidneys and the liver. Kidneys. You see, this, look how the liver is. Liver. If these whitish one is vessels, because you remember fluid. For the vessels now, blood is different from fluid, clear fluid. Blood, because of the density, blood is whitish, but clear fluid is dark like this. This is the gallbladder. If dark with bile, it's dark because CT scan. Remember what I told you. These are the kidneys with contrast now. The reason why they are white, not like soft tissue, they have a contrast within them. And contrast, remember, it is too white. It's off-white as density. This is the spleen. Can you see how the spleen has the same density as the liver? These are the vessels, like this is the abdominal aorta. This is the inferior vena cava here. This is the left renal vein coming from the IVC, you know. So this is the bone now, the vertebral body, the major psoas muscles. Those are the soft tissue. This is the fat. You know, this is air and intestines. You know, from this, you can see everything in details. So that's the reason why cross-section imaging, MRI and CT, they are very far better than conventional radiography in terms of details, in terms of contrast resolution. Contrast resolution now, in the liver, within the liver itself, you can differentiate soft tissue from the vessels, from other point, from fat, from bile. You know, that is contrast resolution. If it was an X-ray, you can't differentiate these things like that. You can't. All right. All soft tissues will look the same for convention, but it will be easily differentiated from the bones. All right. So, advantages of CT scan. First, number one, it has high contrast resolution of images. That one you understand. The difference between high contrast resolution and spatial resolution. I will ask that question. Mwabyumvise?
wari wavuze ngo
Wabivuze.
Data mwabyumvise, twikomereze. Advantages ya CT scan, number one is high contrast resolution. Number two, in imaging bones and lungs. Very good. CT scan is good in bone imaging and the lungs imaging. And number three, for contrast we give, that it's not good for the body. It can even harm the kidneys. You know, it's not good. But for CT scan of the bones in an orthopedic patient, we don't use the IV, we don't give contrast. So that's another advantage, by the way. Number four, it is now available. It's available. When I was at your level in medicine, I remember we didn't have any CT scan in Rwanda. But now we have a certain number. It's almost 10, more than 10 cities in Rwanda. More than 10 cities in Rwanda. But that time, there was no city at all. and it is very fast. Scanning a patient, scanning a chest, is in seconds. It's less than 10, even 5 seconds. You scan the chest, the whole abdomen. But for MRI, it can take 20, 30, even more minutes. Patient lying in the machine. So that's another advantage. The CT scan is faster than other modalities. Limitation now. Limitation number one, it can produce artifact due to motion or due to metal. If you have a metal somewhere in the body, post-surgical metal, the structures behind that metal will not be able to be seen because of that artifact on CT scan. Number two, limitation number two, it has a low contrast resolution for soft tissues, meaning for like muscles, CT scan not that good compared to MRI. MRI can differentiate, can diagnose anything from the soft tissues than CT scan. Number three, as the limitation, it's about exposure to ionizing radiation. Pregnant women, very difficult to do CT scan. And you have to know that radiation dose, X-ray, the number of X-ray, radiation dose is much higher in CT scan than for conventional radiography. Much. CT scan send a lot of radiation. And number 4, 5, it has a higher cost. It is expensive compared to conventional radiography. And even number 6, I can add that even if I say it is available now, you cannot compare the availability of CT scan with conventional radiography or ultrasound. No, it has still some limitation that. So the main application of CT scan now. For head, it's mostly used in a trauma case to diagnose hematoma or fracture. Tumors, CT scan can diagnose very well tumors of the brain, even if MRI can add more details, but CT is good enough to diagnose any intracerebral tumors. Stroke, infarction, either hemorrhagic or infarction or ischemic. CT is very good in diagnosing those strokes. Complication of HIV as infection of the brain, abscesses, or other infection. CT is good in diagnosing those diseases. Brain abscess, CT is good in diagnosing brain abscess. MRI can give more specific findings, but CT is really enough. For chest, mediastinal disease, CT is better than MRI. Tumor, because of air around, tumor staging prior to surgery, CT is good. Diffuse lung disease like interstitial lung disease, for example. There is a technique we use in a CT scan called high resolution CT. It's when we do very thin cuts of the chest and be able to diagnose even a very small lesions in the lungs. CT scan is very good, even the best to diagnose those small lesions in lungs. Pleural disease, pleural effusion, disease. It's very good. Other areas, soft tissues or pancreatitis, even trauma case, liver injury, fracture, must take the abdomen to see there is antithesis in the liver organs, peritoneum, fluid, or tumors, and masses, no diagnosis, and you become a doctor, you will know, this patient, I suspect any pancreatitis. Let me do CT. Let me ultrasound may be sure or not much, but CT can show. Appendicitis, CT scan is good in showing it. Let me request for CT scan. For the spine, CT is very good in demonstrating the vertebral fractures. Prolapse or disc herniation, CT scan is not that good. MRI is the best, but CT can still give some idea, some orientation. For infections of the spine, CT is good enough, but MRI is better. For tumors, CT is good, but MRI is still better. All right. For musculoskeletal, muscles and the bones, normally plain conventional X-ray for complex bones like calcaneus, like tibial plateau, like what else? Like any joint. Those are complex bones. CT scan, we can request a CT scan because CT scan will give more details. You can do plain radiograph of the joint of the knee post-trauma and it looks like normal. But when you do a CT scan of the knee, can diagnose some fractures from those complex bones, like acetabulum, fracture of the pelvis, acetabulum, like tibial plateau, like soft tissue tumors. You can either use CT to diagnose better than conventional radiography, but MRI is far better than even CT scan. Something you have to know, something you have to remember always. Let me tell you, doctors, always remember this. Always remember this. CT scan has a high amount of radiation compared to conventional radiography. Like example, one head CT scan can give a dose equivalent to 115 chest X-rays. Imagine. Instead of doing a head CT scan, do 115 chest X-rays. Those 115, they give less radiation than one CT scan. One chest CT scan can give a dose equivalent to 100 chest X-rays. One abdominal CT can give a dose equivalent to 500 chest X-rays. Can you see that CT scan can give really a big deal of X-rays, of radiation, ionizing radiation to patient. So when you want now to decide to request for CT scan, you have to think twice. You have to think twice and say, hey, is it really necessary? Why don't we use ultrasound? Why don't you use conventional radiography? If it can really give a diagnosis, instead of just exposing my patient to high amount of radiation. Okay? Okay? Okay. Another modality about ultrasound. Ultrasound now, I told you, ultrasound doesn't use ionizing radiation, X-rays. It uses what you call sound waves. People call it ultrasonography, others sonography, others sonogram. Those are the names you can use. It was discovered in 1950, long ago. So it uses what you call sound waves. Those sound waves now, they are very high frequency sound waves that will pass through the body. Now, when they meet different structures in the body, Those sound waves, they can either or deflected, or they can come back to the transducer. That material used to scan. You know it, I think. We call it transducer or probe. It has an interface space where that can receive the waves from the body. It sends the waves through the body, but also receives the waves from the body. So now, hear me very well. When you switch on the machine and you apply the probe or the transducer to the body, the sound waves will go in, and they will emit different structures. For example, air. Air, it is an enemy of ultrasound because air blocks ultrasound waves completely. The waves cannot pass through air and go and see something behind the air. For bones, even bones can block big amount of ultrasound waves. Not all, but some big number. But for fluid, something fluid, it's a very friend of ultrasound because fluid can allow sound waves to pass through and go behind that fluid and look at other organs. That's the reason why sometimes we use some organs that have fluid, like gallbladder or like renal bladder, to be able to scan in the pelvis. You take the patient to feed the bladder so that bladder can be like a window for us to see around behind there and there, because fluid is a friend to ultrasound. The ultrasound waves, sound waves can pass through it and see behind, on side, and everywhere. Okay? And it doesn't use radiation at all. And it is very much available. And it is less costly, not expensive. Ultrasound machines are everywhere everywhere. You can even buy it in the market today and you go at home. I'm exaggerating, but they are everywhere. It can be used also in deep organs, like even blood vessels, pathology, what you call Doppler scan, obstetric scan with the 3D or 4D capabilities. Yeah, ultrasound guided biopsy, orienting for you to take a tissue from deep organs like in abdominal liver. You can use ultrasound to orient you to know where to take that biopsy. But something very important you have to know: ultrasound scan, it is a user dependent, meaning people can see different diseases using the same machine, ultrasound machine. Like, the country will have many what we call sonographers. So there are those people who are not medical doctors. They go to study how to use that machine for 6 months. They come and start scanning patient. You cannot compare that person, what he found, his report, with me, who has done 4 years at school, learning how to do and have a background of medicine. You cannot compare. It's a user dependent. You will use the same machine, we'll see the same things, but we'll produce different report. We'll even be able to see different things. It's user dependent. It depends on which person is using that machine, is doing it. Very important. When you become doctors now, you have to remember this. So user dependent. Don't just send patient, say he has a cancer, and they say, you have a cancer patient. It depends on who has done it, who has said it. I hope you know how ultrasound machine look like. This is one example of ultrasound machine where you have this panel where you can use it in different way. You have a gel. We use gel to. Do you know why you use a gel on the skin? Because if we apply the probe on the skin, between those two interfaces, there is air. And remember, air is an enemy to ultrasound waves. And those sound waves will not be able to go into the body. And now we apply gel so that can remove the air, so that that interface, the interface I'm talking about is this here. The interface can be applied to that gel and send the maximum of waves into the body. So we have different now probes. Like this is what you call linear probe that we use in the abdominal scan. This is what we call linear. It is linear probe using superficial structures like vessels and skin. That is like a transrectal, transvaginal probe where we use ando. It is, we use it, we introduce it inside organ so that we can diagnose better. Because when this interface is near where the disease is, you can see it better. We have any cardiac probes, different like this one. We have obstetric probes, different ones. You know, we have intraluminal probes. They are not here. You know, it has different probes, and we use them different according to where you want to examine. All right. Like this is an example how this is clean. As you're scanning now, even ultrasound, it's cross-section imaging also. It's cross-section, it is in cuts. And again, ultrasound is a real-time examination, because if there is a disease, you are seeing a disease, we are looking at something, you are scanning as you are looking at disease at the same time. You are not just producing image and look at it later. You are scanning as you are looking at where you are scanning. If the disease you are seeing, looking at it at the same time, live, and you can say this patient has this and this and this before even you do a report, before even you look at the images afterwards. All right, it's a relation examination and it is a cross-section imaging. So those are different probes I have told you. There are many. Like this is calvilinear convex for abdominal, for transvaginal, transrectal, for high frequency linear probe for superficial structures, vessels, Doppler, small things, subcutaneous nodules of masses. This is for 3D, a 3D imaging from, for example, in obstetric, we use this one. They are cardiac, they are endoluminal, they are different probes, transducers or probes, okay? So different body tissues now produce different degrees of sound wave reflection. A tissue of high echogenicity. That's a new word. Echogenicity, it's a term we use in ultrasound. A tissue of high echogenicity, it is a tissue that reflects more sound and appears bright on ultrasound. Can we understand this statement?
Yes.
Come back.
For example, I'm examining abdomen. I'm scanning abdomen. When I'm scanning abdomen, my sound waves will go into the abdomen and they will meet different organs. And different organs will reflect, will bring back those sound waves to my probe at different degrees. Now, much probe, lift them, broke them and lift them, will be called, that organ will be ache. it reflects much echoes, right? Hypoic, and my screen tissue that not reflect much echoes called hypoechoic because it doesn't reflect much sound with me. It will appear dark on ultrasound. Do you understand those two? Differentiate those two. Tell me one can explain to me.
Yes.
Tell me your name and explain to me.
My name is Christian. As you said, for the ultrasound, we have to differentiate two kind of tissue, hyperechoic and hypoechoic. For the hyperechoic is when the transferred sound waves are the tissue which will reflect more, and it will appear bright on the screen.
On the screen.
So it will be hyperechoic because it causes much echoes. It causes much echoes. Reflection. So for the hypoechoic is a tissue which will not reflect more, which will not cause much echoes. It will appear dark on the screen.
Meaning the sound waves have much passed through it and continue going into the body. All right?
Yes.
They didn't come back to my probe so that I can see it on the screen. Fantastic. You have understood. So, listen, let me continue. So, then, pure fluid. I told you that fluid is a friend of ultrasound. Pure fluid reflects no sound. Pure reflects no sound at all. And is said to be anechoic. Without. There is no echo. Anechoic. And being seen as black, totally black. All right? Because when you're scanning like a full urinary bladder, Sibio, urinary bladder, you are scanning it. My sound waves will pass through it completely, almost 99%. They will not come in the bladder. And now on my screen, I will see the urinary bladder as something dark, black. And it is called anechoic. Anechoic means without no sound. There is no echo. But when some fluid have some debris, it's not pure fluid. It has some debris, maybe, and it will reflect some. It will reflect some waves. And that time, I not call it an anechoic structure. I call it hypoechoic. You remember, hypoechoic and anechoic, they are a bit different. Anechoic is used for pure fluid. There is nothing blocking my sound waves. Everything is passing through. Nothing is coming back to my probe. By understanding that now, there are two.
Yes.
You say on hypoechoic, the image is going to be dark on the screen. Yet you say on a pure, on an anechoic, there is no echoes to be reflected, and then it's going to be totally black. How are they
totally black? Too dark.
So is it for the hypoechoic? Is it light black or how?
The darkness is different. The level of darkness is different. For hypoechoic, it's dark, but not that totally dark black. For anechoic now, anechoic is totally dark because there is nothing has come back. You understand?
Yes.
It's clear. Okay, it is difficult maybe to understand it from the screen like this, but from the practice, when you come for rotation, you will understand very easily. So there is something you call in ultrasound. There's something called acoustic enhancement. Acoustic enhancement. It's a term we use to describe our image or our disease. Acoustic enhancement is when you are examining a structure that contains fluid. And because all my sound waves will pass through, behind that structure, it will be whitish. Because sounds had passed through and has been concentrated behind that structure. It is called now, that whitish behind that structure, it's called acoustic enhancement. And it is a sign that the structure you are examining is cystic, it has fluid. By the way,
question.
That is even another. Wait, before you ask a question. Wait. Just follow, you'll understand. Now, when you are examining another structure that will block or that will reflect the sound waves, all right? Behind that, the sound waves will come back to me, and on my screen it will be white. But behind that structure, behind the bone, behind the stone, behind the calcification that will block much sound waves, there will be a shadow. Instead of enhanced white, but shadow, because nothing has gone through that structure. That sign is called acoustic shadow. And that will mean the structure we're looking at is a stone, it is something that has blocked, something solid that has blocked my sound waves. It's clear.
I was asking whether may show us some more images that consist with acoustic enhancement with acoustic shadowing.
Yes, let me see if I have them. That's very good. But the idea, you can get the idea at least.
Yes.
Okay. Can I go to another slide?
Okay.
Where do you go for lunch? When do you go for lunch?
At 12.
At 12.
Can you give me some 15 minutes? I finish this.
Okay.
Are we going to have a course afternoon again?
Yeah, for sure.
So can you continue that?
But I wanted to finish there. Like let me see the slides. Like 1, 2, 3, 5. There's some.
Can we start on next when we get back?
We continue where we are. Okay.
Yes.
Can you allow me to finish? Can you allow me to finish with ultrasound at least?
Come back.
Can you allow me to finish sound? Is it 1, 2, 3,
No.
4, 5, 6.
Can we get back and continue?
Okay. At which time can you continue?
At 2.
At 2.
Yes.
Hello. We will probably continue from there.
Need to be close.
Listen to me. Listen to me, guys. Listen to me. Hello.
Yes.
Hello, student.
Yes, we are here.
Can we start at 2 exactly?
Yes.
Yes.
Okay. Thank you very much.
Thank you.
You're welcome.
Our